Hi everyone, good afternoon and welcome back from lunch. We're all fueled up, ready to go to talk about audits, right? So a little bit about me. I'm Ann McMillan. I am a health insurance specialist and I hail from the Chicago Regional Office. I am an account manager and I oversee a large Medicare Advantage organization as well as SNPs. I have a background in PACE as well, and then a distant experience with long-term care survey and certification. And of course, I'm a public health service officer, and I'm a nurse practitioner by trade. So today, and also to tell you too, I was privileged to be part of the work group that developed the protocol for the SNP model of care. And so it's good to be present today to talk about really what went into the protocol, a little bit about that, as well as coming full circle to really talk about how the audit year went, keeping in mind all the feedback that we've heard so far, and then really then to take a look at where we'll be going in 2014. So our objectives for today, going on to slide 2, so again, discussing the SNP MOC protocol for 2013. We'll briefly review those elements and a background as to why they were selected. We'll share some common findings and the major learning points that came out of the audits this year, both from the plan sponsor's perspective, from what we've learned, as well as from the audit team's perspective. We'll discuss some best practices that were observed and shared with the audit teams during the audits. So hopefully that will be helpful to hear for you. And again, the overarching goal today, discuss lessons learned. We'll relate what we can to and talk about some of the proposed changes that are going to be or that are currently being discussed for the 2014 audit protocol. And then really address what are some opportunities for future guidance as well as training. So on to slide 3. Just because there are a variety of probably CMS staff that are on the phone as well as staff from plan sponsors that could be new to this area, whether you're new to SNP, model of care audits overall, or SNPs overall too. This is just, again, common acronyms you'll see throughout the presentation. So it's just more of a reference. So really getting into more of the presentation here. Again, going into the SNP model of care audit overview, really looking at the audit elements. On to slide 5. So really, here are the audit elements currently for the 2013 protocol. Again, that population to be served, identifying what is the target population or what is the population that you're taking care of with your SNP. Also with element 2, there are a lot of areas or a lot of different elements rolled into this area. Health risk assessments, the interdisciplinary care team, the operations that go into how that care team cares for the members, oversees care and services, as well as the implementation of the care plan and use of evidence-based guidelines. And then the third area, that plan monitoring performance, the overall quality review and performance and evaluation of the MOC. So I wanted to take a moment and just say the elements reviewed for the 2014 protocol will look pretty close to the same as this. But so far, the proposed changes for the actual methods of evaluation, what the audit team will be doing, the step-by-step areas of the review, they'll look a little different. So as we go through the presentation today, I'll again kind of make note of where those changes are being discussed. And of course, we'll have time at the end of the session today to talk about any specific questions you have, and that's where Lorelei and Jennifer are here too with me. So the good news is that CMS has definitely heard your feedback loud and clear throughout the audit year, and again, that feedback is really has been considered and discussed as not only for proposed changes for the 2014 protocol, but definitely for how the audit teams can be trained about the protocol. So on to slide 6. So what went into the background with the MOC audit protocol? First of all, there were 2 independent reviews were done in contract year 2012. And one of the reviews looked at how SNPs were implementing their MOCs and what were some of those lessons learned. And another project observed areas for improvement in how plans could improve in writing their MOCs. And based on those findings, and Debbie had mentioned the HPMS memo dated February 12, 2013, that really nicely summarized the findings, the major learning points, as well as CMS expectations going forward, that it's a great reference. But from that memo, what the work group identified, there were some prioritization of maybe some elements that needed to be focused on for this first audit year. So on to the next slide, a little bit more about the background. So of course, for this first audit year, CMS did not audit all of those 11 MOC elements, or you didn't see them in those 3 main areas for the protocol. And understanding too, many of those elements, as we talked about this morning, one rolls into the other. So really a lot of what the MOC audit protocol addresses, a lot of those MOC elements are being addressed there. But mainly CMS wanted to use this first year to really gain insight into, again, gain some experience and gain information on what some of the best approaches would be, especially as things develop for subsequent years. So therefore, the main areas for the model of care improvement, those summarized in the HPMS memo that I just referenced, everything was rolled in. That's how everything was rolled into that 2013 protocol. So moving on to what were some of the common findings, as well as what were some of the common concerns seen in the SNP MOC audits in 2013. So like this little guy in the boat, basically putting this presentation together, we looked at the various results that were currently in draft or drafted, and really took out what were some of the more common areas that really to talk about today, what could be some good learning points. And I'll also, as we go through these, I'll go through what are some areas in the 2014 protocol that are being discussed that could present some changes in the future. So on to slide 9. Starting with enrollment verification, this is, again, identifying that population to be served, that audit teams look at how that SNP identifies and verifies that eligibility for the members that are being enrolled in that SNP. And as we know, there are various ways that SNPs will do this, depending on your SNP type, the population you're caring for. So in the enrollment verification element, plans did very well overall. This is probably one of the more straightforward, at least from an auditor's perspective, it's one of the more straightforward elements to review. So there were really pretty few findings identified across the board, especially with dual eligible special needs plans. But I did want to just point out a few things that popped out related to C-SNPs and I-SNPs. So with the C-SNPs, there were instances of providers not completing that annual recertification of the chronic condition, again, keeping that member enrolled in that C-SNP. Not a widespread finding, but just a few. And with I-SNPs, there were instances that the plan did not ensure, or that there was evidence ensuring that the third-party entity that was doing the level of care assessments, that they were using a state-approved tool. And as we know from CMS requirements, that if you are using a third-party entity, you have to use a state-approved level of care tool. Also, the I-SNPs were not always verifying that the institutional level of care was being completed in a timely manner. So just a few findings that came out of those enrollment verification elements from the audits this past year. So on to slide 10, and this was definitely, hearing comments from this morning and questions, the HRAs are definitely a hot topic, and bearing that in mind, but just also wanted to call your attention to what were some of the common findings also from the audits. So health risk assessments had these findings as indicated here on this slide. They were found to sometimes not be timely, and again, as mentioned this morning, that they have to be completed within that 90-day time frame of enrollment. Reassessments are not always completed timely, and we know that they need to be updated at least annually. And also, CMS would expect reassessments to be completed whenever there is a change in the member's health condition, especially a more significant change. For example, if during an audit where the audit team were reviewing the sample, if a member is found to have had a broken hip, or a stroke, something that would put them in the hospital, there's some care transitioning needed to happen there. They need to go from the hospital back to an institution setting, things like that. The audit team would definitely expect that there would be a reassessment conducted in that situation. In other results, there were instances of the HRA not always addressing all of the members' active or more problematic health concerns. And this would come up as a question during audits because depending upon the SNP type, and again, depending on your model of care, what you describe in your model of care, it will depend on what in the HRA is going to flow over to the care plan, and I'll discuss that in a few minutes too. But really, HRAs need to include all current information, the medical, psychosocial, functional areas for that member that the plan sponsor, again, attests to in the model of care. So the audit team will need to, especially going forward in 2014, there's guidance for, proposed guidance for audit teams to really ensure that they're looking at that plan sponsor's model of care and using that as a basis for their review. CMS recognizes there are many formats that an HRA will take on. As discussed this morning, there were a few plans that talked about they send out their HRAs and the member sends them back. You're trying to do some phone outreach to that member. That member may not be able to be reached, things like that. There's going to be some various ways that plans need to do outreach to that member to ensure that that HRA is completed. So CMS recognizes it's going to be difficult to get that completed. And there are going to be various ways that plans need to do what they need to do to get it completed. But mainly, again, the information in the HRA needs to identify the active problems and those special needs that the member has at that given time. So speaking to the last bullet here, that there were times where there were gaps in documentation where the plan systems were updated or transitioned over to a new platform. So if your organization is planning anything like this in the future, just something to keep in mind for your own internal monitoring procedures as well as perhaps a CMS audit that could be coming on down the line, to be mindful of that and have ways that the organization can have a backup for documentation of especially how you're doing the care coordination for your members. So, and I think I've already mentioned this, but again, should just reiterate that for 2014, in the methods of evaluation, that the audit teams will be reminded that the items in an HRA may not always flow over to the care plan. So audit teams will be reminded of that. And again, it will totally depend upon the plan's model of care. So really, again, going back to that model of care as the basis for the review. So I know that was feedback shared with CMS, so be assured that that important part of your feedback is being discussed for changes for the 2014 protocol. So moving on to interdisciplinary care teams, and that's slide 11. A few common findings. In a few cases where non-clinical personnel were doing the intakes for the health risk assessments, the members' care needs were not always properly prioritized for care planning. So where the audit team saw this and where things slipped through was where certain health conditions or the special needs that were noted during the review, that those were not included on the care plan. Again, also keeping in mind that the audit team will take the model of care and use that as a basis for their review. There were instances a few times where plans needed to show documentation in how their care team, their interdisciplinary care team, was collaborating. And this is where CMS recognizes where documentation is going to be different for every type of SNP, depending on what care model you use, whether it's the staff model or the network model. Audit teams will need to keep in mind, too, that the staff may not be able to meet face-to-face, of course, and that also that there are, with the network model especially, you're going to have those virtual meetings. So, but really then what the organizations what you have to keep in mind is how are you documenting that that's happening? So that'll be a challenge, but it'll also be, it will be something that the audit teams will be still looking for in how you're implementing your model of care. And then another expectation, too, would be how this would all flow. Is this flowing into the into the individualized care plan? So on to slide 12, talking a little bit about provider training. I should talk about care plans, but that'll be on the next slide. But and again, keeping in mind this is another hot topic. And we talked a little bit about some questions this morning regarding this. But these, again, were some of the common findings. And there were a few, there are some proposed changes in the 2014 protocol also in this area. Again, recognizing that especially with large networks or even small networks, it's always going to be a challenge with trying to document every single provider as having done their model of care training. So CMS recognizes that. We've definitely heard your feedback about that. And so based on both the SNPs and the audit team's experiences, as an auditor, this was one of the elements that is a little more difficult to review. That, again, recognizing those proposed changes for 2014, but CMS does expect still, as was mentioned this morning, that all SNPs will still offer the mock training and provide the appropriate training materials to the providers. And now about care plans, slide 13 here. So what were the common findings with care planning? Probably what you would expect is that sometimes audit teams would not find that a care plan was initiated. Something happened with a member, some communication breakdown there, but just a few instances of care plans not initiated. Maybe the care plan was not updated after a reassessment and a noted change in the member's condition. With the care plan, sometimes they did not always address issues found in the HRA. And again, this became a point of contention and an area of concern from plan sponsors, and we heard plenty of feedback. But and based on that feedback, again, audit teams will be trained and instructed to always go back to what is in the model of care. How do you describe that in your model of care? How are you approaching care planning? Are you care planning every single issue on that HRA? Or are you care planning just the more problematic areas for that member's care? In other areas, a few plan sponsors could not show the implementation of the care plan through the evidence at hand during that audit, whether it was claims, whether it was case management notes, again, going back to what that particular plan's model of care stated. So again, going back to documentation. Slide 14, on the last element here on monitoring and evaluation, overall there were pretty few findings looking through the various audit results, which was good to see. But just wanted to mention for the presentation today just a few of just some feedback of what a few of the findings were. One finding was that the plan could not provide documentation to show that their model of care was being monitored and reevaluated by plan leadership staff. Again, going back to that particular organization's model of care, if it was perhaps a quality improvement leadership staff person, and then when the audit team went to look at what the documentation was, there was really no indication of really who was following up on the activities that the model of care described. Audit teams saw that the model of care evaluation information, such as health outcomes data, whatever data is being measured and reported, it was not presented to the board or other leadership or key stakeholders that, again, is communicated in that plan's model of care. So, again, feedback for organizations is to be mindful of how you're documenting, how things are being, or how would you show an audit team that you're reporting to the proper stakeholders or to your plan leadership, however you're describing that in your model of care. So, excuse me, so really just the expectations are too that the audit team would need to see that the documentation available would show that the SNP is collecting and analyzing, reporting, and also reevaluating their model of care. That the SNP has prescribed methods for data collection, so showing the audit team how you're collecting your data, how that information is accessible, how you're communicating that to your various stakeholders. And overall, showing during the audit that the SNP is looking at its processes, how you're looking at the model of care, monitoring it, responding to lessons learned, which is the last bullet point here, that identifying those corrective actions and carrying them through and making sure they're being implemented. On to slide 15, we'll talk now about some best practices. These are areas that were observed during audits as we're doing the review, or things that were being shared were shared with the audit team as the audit went along. And keeping in mind these are, in a few areas, things are, SNPs went way above and beyond this CMS requirements, and I'll make note of a few of those. So slide 16. In health risk assessments and care planning, for instance, a few SNPs they set their own standard of really going above and beyond the CMS guidance in 16B, that they were doing the HRAs within 30 days of that member's enrollment, and then every 6 months thereafter. So pretty similar to the PACE model. But again, noting that this goes way above and beyond the CMS guidance. But the SNPs felt that this really made them successful in, well, not only keeping in tune with the CMS guidance, but really staying in touch with their member needs, especially if they had a population that had a lot of more complex, high acuity members. The second bullet point here is utilizing advanced practice RNs, such as nurse practitioners, to serve as care coordinators in the institutional settings, such as a nursing home. And really where this will help is in that care transition, again, keeping track of member assessments, keeping track of that member's needs. And in a place such as a nursing home, members' needs can, as we know, can change so quickly. So that was another observation. Slide 17, again, in the area of HRAs and care plans, talking about electronic systems, and again, these are observations of really what helped certain plans be so successful in their implementation of their models of care, that having an electronic system, and we know this is really the ideal. This is the perfect, in a perfect world, that the electronic system was easily accessible by not only plan staff, but especially the case managers overseeing the members' care, and also providers in the network. I know I was a little surprised to see this, but that they were ensuring that there was gradually more and more accessibility out in the network. And so as we can see that the HRAs would easily be viewed, accessed, documented, updated as needed. The care plans especially could be accessed by primary care providers or specialists. Those phone calls to members with the HRAs, trying to get those completed, any of the care coordination notes that need to happen, everything would be in that electronic system. And also with keeping track of claims, keeping track of medication, perhaps medication reconciliation, things like that. Utilization of services can be clearly displayed in those electronic systems. So definitely a powerful way, very effective way in documenting care coordination. And slide 18, talking about interdisciplinary care teams, again, few ideas here. That nurses were embedded or assigned permanently to hospitals and clinics, and these are RNs that work for the health plan, that they're located in these hospitals and clinics within the network to, again, assist with member assessments, assist with care coordination, really helping communicate during the whole, especially with care transitioning. RNs or even social workers can visit members in the hospital or nursing home to complete reassessments, any discharge planning needs, again, helping with care transitioning. And also another observation, again, going back to documentation and using electronic records, is that another plan used their documentation in an electronic record to really keep track of phone calls to members, encounters with members, providers, and specialists. So on to slide 19, talking about training. And again, these were observations of how plans were doing their very best to keep track of the provider training. That plan sponsors were doing outreach to provider groups. They were going on site to complete training as best they could, and they were being successful at that. They were catching a lot of providers by doing that. Also providing the training online for provider groups to complete or making it available, and also gathering attestations of training completion with the plan then periodically monitoring to make sure they followed up. And again, keeping in mind what we talked about a little bit about this morning, there are also discussions about the 2014 protocol, about this, the expectations with this going forward, and again, offering the training to the provider groups and showing evidence that you're doing that. And so hopefully these observations will, again, they'll serve as good ideas of how to do that. So slide 20. Different areas in the monitoring and evaluation element. SNP leaders would initiate projects with both their internal as well as external stakeholders, especially in focusing on care transitions. So this was a good observation to see just how were SNPs really looking at ways to take their model of care and how were they communicating to their stakeholders, how are they using that information to improve their processes? How are they, in the second bullet here, SNPs incorporated, again, those electronic records, utilizing them also for data gathering and tracking their quality measures. And a lot of that overlapped with what they were already doing, was trying to track their STARS measures and things like that. But this was also named as a way to do it also for their model of care. And also incorporating the MOC reporting or communication of the MOC evaluations to leadership, key leadership, and also the board. So a way to do this is to really make sure that that periodically throughout the calendar year that there would be designated dates that the MOC staff would report to the board. Okay. So going forward in 2014, again, I've tried to brush on some of the major areas where your feedback your feedback as well as CMS audit staff feedback and subject matter experts, where all the feedback has been helpful with contributing towards discussions of the proposed changes for 2014. And going on to slide 22 here, what were some of the frequently asked questions? What were some of the more frequently addressed topics or concerns that came up? They would come up, a few would come up before the audit, perhaps right after the audit engagement letter was sent. More minor things like clarifying the universe, what was going to be included with the review, and confirming the types of documentation needed. During the audit, again, these are some of the more hot topics that came up. And we've talked a little bit about how this feedback is really helping to guide what will be in the 2014 protocol. But for instance, difficulty contacting members to complete HRAs or even to complete a care plan process. Different things of, okay, what types of documentation would be needed? There were also, so really when audit teams presented these questions to the subject matter experts, it's one of the main questions back to them was let's go back to the model of care, the plan that you're auditing. What does the model of care state? So that came up frequently to just redirect the review back to really the basis of the review, which is the plan's model of care. And slide 23. Just to reiterate again, the different methods of feedback. There were various listening sessions. I was able to be a part of some of those. And again, they were invaluable with gathering really information about where could there be some gaps in the protocol, what needs to be tightened up in the future, where maybe were there some inconsistencies across audit teams, how can that be addressed? Things like that. So again, the comments gathered, thank you for those, and again, they're being considered and discussed for the future draft of the protocol. So ultimately, what we talked about today, again, just to emphasize again that the training of the audit teams, it is forthcoming. I know that the draft of the 2014 draft isn't released yet, but when it is, there will be definitely guidance and training. So, in conclusion, I feel like I flew through this. Obviously, many lessons learned, many firsts in 2013, as well as the lessons learned with the audit protocol. As always, with audits, there's plenty of dialogue that happens, and that's fine. It really helps us to examine your processes, how you're implementing your programs, where are the successes, where are some things that need to be worked on, what are maybe some areas of the policy or the protocol for audits, what needs to evolve. So there were some truly excellent best practices observed in really how SNPs are ensuring that the specialized care and services are being delivered. And it's always very refreshing to see how different programs are being implemented. And so with the new audit year, we know that the protocol will be released soon. There's going to be many training opportunities. With the model of care requirements, the new requirements coming out, we heard about training opportunities coming with those. So again, looking forward to the 2014 protocol, and again, we've heard your feedback. It's been very, very helpful, and discussions are ongoing. So with that, the information covered today, I hope it's been helpful. Again, giving that perspective from the CMS side of things. And again, I was part of the work group that developed the protocol, and also observations as an audit team member and audit team lead. So whether you're brand new to the SNP MOC world, if you've not had an audit yet, or whether you are one of our veterans from last year and you've been through the process, again, hope these insights have been helpful for you. So my part of the presentation's done. I'll stop talking, and I believe we can move on to the Q&A portion. And again, Jen and Lorelei are here to help answer questions with me. So I think we can take questions from the room first, and then we'll move on to the phones and also the web chat.
Yes, hi, Giselle Dayano, Coventry Healthcare, Florida. My question is regarding the SNP model of care training for the providers. During our 2013 audit, the expectation was not just to demonstrate that we had given the providers access to the training, be it online or in person, but also to demonstrate proof that that was completed by all providers. What are the changes expected for 2014, if any, and what can we expect in terms of that for the next audit year?
Okay. I think I can tackle the part of it, and then so far discussions for the 2014 protocol, again, as far as what I know, and then I'll definitely let Jen and Lorelei talk too, is that I'll say that the discussions are continuing, but really it's more turning the focus to looking at how the SNP is offering the training versus looking at every single piece of documentation to see, okay, ensuring that everybody completes it. So the piece is more, the focus would be more on what are the ways that you are ensuring that the training is being offered or put out there for those providers. So I think is that about it?
Yeah, I think that about covers it. I would just reiterate, I think what we're trying to do is look at what you said you would do in your model of care. How would you train them? How would you verify that everyone received that training? And then kind of doing our check in response to that. So I think the level of documentation is still somewhat under discussion, but I think we all recognize that asking you to produce potentially each and every certification for each and every individual in your network may be a bit much. So I think we're trying to find some middle ground, but we'll be going back to what you said you would do to verify that they received that training and making sure that you're taking those steps in your organization. So basically following that.
Okay.
And my name is Tom Stanner. I'm with Molina Healthcare. I appreciate you taking the time to be here today, and also want to thank CMS for recognizing how important the model care is and inviting us all here today to spend time with you. So you mentioned the 2014 audit protocol has not been released, and it should be forthcoming. Can you share with us about how many plans CMS intends to audit in 2014 and what the timing might be? And I would just, in closing, say that, Molina, we weren't one of the small handful of plans that did undergo an audit last year, but we did an internal audit. And I know lots of plans are trying to get ahead of this because we recognize how important the model care is.
Sure.
Our audit strategy for 2014 is in its final approval stages. We generally try to conduct and this is audits total, not SNP MOC audits. We generally conduct audits of about 30 sponsors in total each year. That will probably be around the same number that you can expect for 2014. Of those 30 or so sponsors, I don't know at this time how many have a SNP. I think it's about 10. So we obviously don't release the list of plans that are going to be audited. You'll find out that you're being audited when you receive your start notice, your engagement letter from CMS. I will say that while the 2014 SNP MOC protocol is not out yet, as Ann said, it will be out shortly. I also would just encourage all of you, the 2013 protocol is out. You're not going to see substantial changes in the way of anything more stringent in the 2014 protocol. If anything, there might be clarifications, or there might be, I don't want to overstate, but there might even be some relaxation of certain items in the 2014 protocol. So for those of you who are concerned, who are trying to prepare, who want to do audits internally this year, if you maybe didn't do one last year, look to that 2013 protocol. It's a good starting point, and it's going to give you a very good outline of what you can expect for 2014.
Can I just do it, Bob? Is it right then to think that last year the model care audits were standalone, but in 2014 they'll be part of a regular sponsor audit? Is that what Part D compliance and enrollment, disenrollment, and SNP model care would be one component of that?
It will be one component of the audit, yes. I mean, I think what you're referring to is that whenever we implement a new protocol, the scores are not released for that first year. It's a testing period for the sponsors, it's a testing period for us. So all of you that received SNP MOC audits in 2013, obviously that audit score was not factored into your final audit report. It won't be released to the public. We would do that with any new protocol that was incorporated into our strategy.
Thank you.
Yes, ma'am. Uh-oh.
Hello. Thank
I
you.
can hear you.
Hi, Jamie Brandy from Kaiser Foundation Health Plan. I just wanted to clarify, and I think you might have just addressed the question, but the 2014 audit protocols that are yet to be released, I just wanted to clarify that those audit protocols are based on the existing model of care requirements and not necessarily on the revised requirements that take effect for contract year 2015.
Correct. It'll be based on the 11, the old way, the 11 model care elements. Correct. Yes, ma'am.
Hi, good afternoon. I'm Mary Jo O'Hara with Humana Health Plan. I am looking for some clarification around ICT. In the prior 16B requirements, it spoke to an annual ICT review. That particular language is not seen anywhere in the new model of care matrices. And if that is still a requirement, could you please expound on what that exactly means, or what you would expect to see?
Okay. An annual review. I'm not sure if I can answer that right this second. I'd have to probably get back to you.
I would probably have to defer to our subject matter experts in the room on that one, since it has to do with their guidance.
Okay, all right.
Yeah.
I mean, the new matrix speaks to, the stakeholders and how you communicate with the stakeholders. And so if that is actually a requirement to see that continuous documentation thread between communication and coordination of all the ICT members, as opposed to a review, an annual review, which in my mind speaks more to looking at their claims and their medications and documenting all of that type of thing.
Okay. I think I'll have to, we'll note your question and get back to you.
Okay, thank you.
Yeah, no problem. I think I'm missing, sorry, I didn't mean to
Valerie
miss your
Wilbur, I'm from the SNP Alliance. I had two questions. My first one is, if a chronic condition is by nature a condition that you're going to have for life, why do providers have to recertify, after they've certified that somebody has diabetes or CHF or COPD the first time, why do they have to do an annual recertification of a chronic condition?
That is a policy question that I think goes above my pay grade, but is there anyone here that can address that?
Oh, Susan?
Any of our subject matter experts? That is a great question.
Thank you, Valerie. What I can say is Chapter 16B is coming out. And so we'll have that addressed in Chapter 16B, and that should be out later on this week. But that's all I can say for now. Okay.
All right.
Okay.
My second question has to do with the relationship between the health risk assessment and the individualized care plan. When a number of our plans were audited last summer, there were some concerns about the auditor's approach to what was identified in the individual care plan, and having to have, in every case, every condition that was identified would have a treatment plan. Every condition that was identified would require a visit with a specialist, even when some of our plans felt maybe that the primary care physician was adequate to take care of the need. Every care plan, or excuse me, every condition identified and treatment identified had to have a follow-up claim to show that the plan had in fact carried out whatever was in the treatment plan. But yet, Brett Kay acknowledged this morning that there can be a tremendous amount of difference from one plan to the next based on the complexity of care.
Right.
And he said, for example, maybe a DSNP that has a population that doesn't have complex care needs, maybe their treatment or their individual care plan would be follow up in 6 months because their conditions are stable. And so what our members were concerned about as a result of the audits were that if we had to have that level of intensity and essentially a complex care plan for every member, that you wouldn't have the resources that you would need to devote to the really sick people if you had to have a complex care plan and treatment, situation involved for every member. So I think the way some of our plans were audited last summer was very different from the way Brett explained it this morning in terms of expectations. So I just wonder if you could comment on that.
I can definitely start to comment, and then I'll turn it over to Jen and Lorelei. That feedback definitely was heard loud and clear, and that it was definitely noted that we also heard about differences between audit teams, or not to say that they weren't doing a good job, but to say that there were instances where things were looked at in one review this way, and then applied maybe in not a different way, but just at maybe to certain levels. So definitely that feedback was really heard and is being definitely discussed, and that's why for the current protocol, what's being discussed is really getting back to emphasizing to the audit teams that instead of delving into that almost like member by it as a clinician, as a fellow clinician, it's very easy as an auditor to really hone in on that member and their story. So I'm not sure if that's what happened, but different audits and such, they'll just be different experiences. But taking it a step back and looking at it from a plan view, like what I think was talked about this morning, discussed taking that almost a 10,000 or 15,000 foot view versus from more personalized. So that'll be that is being discussed as a really a key portion of what the training will be, really that'll be emphasized for audit members, especially into the next year. And I know we've talked about too how I'll let Jen mention too that the results are being currently reviewed for really just to make sure that everything was being consistently looked at.
Yeah, again, I would just say I think your feedback has been heard loud and clear, and I think one of the things that we're going to do in training this year is really just emphasize again very strongly that this is an audit that is reviewing what you're doing based on what you said you would do in your model of care. And so everything, as all of those audit elements are applied, it should automatically be going back to what did you say you would do and what are you doing in comparison. So I think that's a big part of training auditors moving forward. Additionally, as Ann mentioned, we are in the process right now of having all of the SNP MOC audit findings reviewed to ensure that, in fact, all findings are really based on what was in a sponsor's model of care and relate back directly to what you said or didn't say you would do in your model of care, and that though that's been applied consistently across all sponsors who got a SNP MOC audit. So just to ensure that that consistency is there before any final report is issued to you.
Hi, my name is Lucy Vigil. I'm Quality Improvement Specialist with AIDS Healthcare Foundation. And my question was more just out of curiosity. You were mentioning common findings included, and you stated some findings for the HRA and the ICPs. So I want to know what number you used in terms of a benchmark to say 30% or 50%. We're a specialized CSNP, so we do care for people with HIV or AIDS, but in terms of a bigger picture and how to compare ourselves against maybe other CSNPs, what kind of numbers did you use to come to those findings?
Okay, good question. And really, as I was preparing the slides, if it was more of a generalized review, not generalized review, but really more of a generalized approach. If I saw it in more than 2 or 3 audit results or sets of audit results, then I definitely wanted to bring it forward, to discuss here in this venue. Other than, I would say, for the enrollment verification element, that because there weren't very many findings overall, across the results, and really, of course, we know there's more D-SNPs than I-SNPs and C-SNPs out there, so proportionally there were more D-SNPs audited in comparison than to C-SNPs and I-SNPs. So where I could see where there were certain things that popped out for perhaps a few of the C-SNPs that were audited. That's how I brought that forward. So it was more of a generalized, there was really no statistical way that I was doing, that I was approaching it, but that's a good question.
Thank you.
Mm-hmm.
Hi, I was wondering if you could speak to revisions to the MOC, especially from the CMS audit perspective, because a lot of plans submitted their MOC and were approved, had their MOCs approved, and they were new plans or did not have experience, and then as they started to implement the MOC, realized that they needed to make some changes to that, with no opportunity, say they got a 3-year approval, to resubmit for 3 more years. What do the auditors want to see? I mean, obviously you're looking at compliance with the core elements, but do you want a red line document? What do the auditors want?
I would say, it depends upon, it's going to depend upon the SNP. But if, as an auditor, what I would look for is something like a red line document, or what information led you to want to change the MOC, whether it was the health outcomes data, results from that, demographics, maybe the demographics have changed for the SNP, things like that. So that's just more from my perspective as an auditor, but I see Susan over there too, to hopefully help answer this.
Hi, this is Susan. If you change your model of care, our current policy is for you to alert the CMS SNP mailbox to let them know that you're going to revise the model of care. And then what you do is, on your original model of care, you do a red line version on that original model of care, so that when auditors come, they will see that this is my original model of care and these are my revisions. You do not need, at this time, you don't need to submit the model of care to CMS. We just need to know that you've actually revised your model of care.
So the email to the SNP mailbox is just a simple, we're revising our model of care, not the detail.
That's correct. You'll say, I'm H so-and-so and so-and-so. We're revising our model of care. We have revised it. We've included our red line. And then I enter that into my little Excel sheet. But when you do get audited, the auditors will see that you have the red line version, and they can tell from the original and where you made your changes.
Okay, great. Thank you. That's very helpful.
And wanted to definitely turn our attention to the phone. So Danielle, is there anyone in the queue on the line?
Hello. At this time, we are going to accept questions over the phone line. If you have any questions at this time, please hit #5. This will allow you to get in line and ask a question. Again, that's #5. This will allow you to get in line and ask a question.
All right. Yes, we have a question. Hi, this is Fred Sherman from ArchCare Advantage. When you audit the when you audit the MOC, you audit the original MOC or the red line MOC?
It would be the original, the current MOC that's approved by CMS.
Thank you.
Does that help? And I think Susan has a little bit to add.
For a revised model of care, the auditors would be auditing the red line version.
Okay.
If you have, say for instance, you have your 11 elements, and you have, you decide to revise your model of care, and you put your red line in there, and then your health plan comes up for an audit. The auditors will be looking, they'll see the original, but they're going to be auditing via that red line version.
Right. Okay. Does that help?
Does that help?
Yes. So it allows you to change your MOC without approval of CMS?
If you are revising your model of care and you're in mid-cycle, you're just telling us what you revised in your model of care. So you're at this current time, okay? We're not talking about the future. because in the future that may change. But currently, that's what would happen. You would tell us, you would, like I said before, go into the CMS the mailbox, and your H number, and say, we are revising our model of care. We have our red line version, so that when the auditors come, they can go ahead and audit that red line version. That red line version has your original model of care in there.
And I think I'll add too that whenever when you receive your audit engagement letter, there's always the opportunity to have a conference call with the audit lead and the various teams that are auditing the various areas, including the SNP MOC, will be on that call. So that would be, I think, a prime opportunity for if you did recently revise your model of care, you notified the SNP mailbox, definitely let the team lead know. So that is just something to know for the audit team to make a note of. And one thing I meant to mention during my presentation is that also there was some feedback during the year about audit teams not being fully aware of what certain SNP types were, including fully integrated dual eligible SNPs. So if there are key features of your plan or of your SNP that you want to communicate, that first call with the audit team would be, I think, a good opportunity. So just something to be aware of.
And I just wanted to clarify, and I hope in this clarification and I'm not further confusing people. Let's try an example. So we're in CY14. Your model of care is expired December 31st, 2014. Okay? That means that you're due to submit a model of care. So that doesn't mean it's a revision per se. It means you're due to submit your model of care. So I just want to make sure that you know the difference. So if you have a model of care that's been approved for 13, 14, and 15, and somehow you need to revise it during CY 2014, you may make that revision. That doesn't mean you have to resubmit your model of care. Does everybody understand that? I just want to make sure you understand.
Okay. Are there any
if you
other?
could go to the microphone. I think I just confused somebody.
No, actually, we had this question before. Dr. Jim Barker, I'm at Scott and White Health Plan. So we're a new DSNP, and we just want to know when the next model of care is due then.
Okay, well, if you're just going to submit this year?
No, we just started.
You just started. Well, it depends on what your approval period is.
1 year.
Yep, then you need to submit again this year.
When?
Oh, application time. Like I said before earlier this morning, your models of care are attached to that application cycle. The application becomes live tomorrow, and it's due February 25th. And if I'm incorrect about that date, I will make sure you know. You're having SNP training on the 15th.
Okay.
There is that SNP training, so all your questions will be answered then. Does that make sense?
Yeah.
Okay.
Okay. Are there any other questions on the phone line, Danielle?
Yes. Yes, we have a question in Minnesota. This is the state of Minnesota. We noted some of the best practices emphasize the use of RNs going into hospitals and other settings, as well as using advanced practice nurses, which of course we heartily support. But we would point out that with states' involvement in managed long-term care programs that many of these SNPs are involved with now, that we have requirements that may vary from using just simply RNs. We may require the use of social workers or allow the use of a combination of RNs and social workers, and that's very important because if we want to integrate the model of care with our managed long-term care elements, we would probably not be able to afford a system that was completely devoted to using RN. So we're wondering if the model of care audits are going to leave room for those other kinds of managed long-term care elements and for the use of some non-medical personnel, which of course is the emphasis of many of the social services that are provided through the managed long-term care support.
Good questions. It's more about the protocol, I think. I can't think of anything. I would expect it as especially with a type of a DSNP that is focusing on care needs such as that. As an auditor, I would want to see, how that's happening and how that flows into the model of care and how that's affecting how the model of care is being implemented. I can't think of specific things about the protocol that would look at services like that, but I think that's one example that as to it just would depend upon that SNP type or the location of that SNP and the care model that it uses. So I think that's as best as I can do right now to address that question, but it's a very good one. Anything else?
And this is Jen. I would just add that, again, it's a best practice. It doesn't mean that it's a CMS requirement. It's something that we identified where someone we felt went above and beyond what we're requiring. So again, I think as we're going out and doing the audits, we're going to be looking to see what you said you would do or how you would conduct this in your model of care.
Right.
So if you've got it laid out in your model of care that it's going to be a mix of RNs and social workers or what have you, then that's what the auditors will be looking for.
Does that help?
Thank you.
Okay. Okay, and just looking at time, do we have time for a few more questions, you think?
We do have some chat questions if you guys would like to address them.
Sure. Let's address a few of those.
Okay, our first question is from Ann Gardner. Her question is there a minimum percent expectation of providers that must complete the MOC training for the health plan?
Great question. I can't think of where in the protocol it would specifically state that, but again, there's ongoing discussions about the 2014 protocol, so it's just something to take back. But I think it's a good question. I can't think of any specific number. We're not putting numbers on things right now that I can think of.
I don't think there's a specific percentage laid out in the protocol. I'm looking at our subject matter experts. I don't know if they have anything in the guidelines. I don't recall of a specific percentage. I don't think we don't have anything in the protocol that says it has to be X percentage.
Right. So not currently. It's a short answer. Okay, next question.
This question is from Jody Reed. Her question is, where can I find the revised Appendix 1 of the MA application model of care?
Off the top of my head, I don't know, but I think Susan will probably know.
This is Susan Radke. You will see, I don't know if you can see it, if you're just listening on audio, the model of care matrix upload document is attached in the slides on the NCQA website. It is also in our packet here under models of care. So you will see the upload document, and it is also, of course, in Appendix 1. Special needs plans application, Medicare Advantage application.
Okay, thanks, Susan. Okay, I don't see anyone else yet in the room here. Any more questions on the chat?
Yes, this one is from Diane Lopez Castillo. Her question is, can you please provide guidance regarding the credentials of staff authorized to review stratified HRA responses? Must it be a RN and or a licensed SW?
I can't think of in the requirements where it absolutely must be an RN or an SW. I believe plans have the leeway to determine who from the interdisciplinary care team is stratifying those needs. So it can depend upon really upon what your organization wishes to do. And also as auditors, we would see then how your organization is carrying that through. So hopefully that helps. Anyone want to add anything? Okay.
We do have one last question from Pat Higgins.
Okay.
Pat Higgins' question is, if we make changes to the goals annually, do we need to redline the MOC and let CMS know and provide a red line?
I think we pretty much addressed that yes, if you modified your model of care, definitely make a note of that, have that red line available for if you were to be audited, have that available, and then let CMS know via the SNP, CMS SNP email box. Anyone else on and I think that's, we're basically, our time is up, but anyone else on the line, Danielle, that you had waiting?
If you have any questions waiting, please hit #5. Hello?
Okay, I think we have time for one more question.
We do have one more on the chat.
Okay, we'll do
All right,
that
this
one more.
question is from Judith Brantley, and her question is, NCQA states 30 days for RMA CMS states 90 days.
Okay. In relation, I think, pertaining to the health risk assessment, if that's what that means, that the CMS requirement is 90 days within that, the member's enrollment. So just to clarify that, that's what audit teams would be looking for, that's what plans are doing in conducting that health risk assessment, is that 90-day time frame. So hopefully that clarifies. Okay, well, I know our time is up. Thank you, everyone, for your attention and your participation. And yeah, have a good afternoon. Okay, thanks.
Hi, everyone. Take about a 10 to 15 minute break, so if everybody could be back by 2:30. I just want to, for the panelists who are doing the SNP panel next, if you guys could just meet me outside the auditorium, just to the left outside the door there. I'll just want to touch base with a minute before your panel starts at 2:30. So otherwise, for everyone else, we're going to take a break till 2:30. So if everyone could be back then, we'll get started and stay on time and get you out of here on time. Thank you. All right, good afternoon, everyone. This is the last panel today, so we want to go ahead and get started and stay on time here so that we can get everyone out on time. I know you probably have flights and trains and other things, so we appreciate your cooperation on that. We have a really good panel to close out the day. I think this is exciting to talk about some best practices related to really, care transitions and care coordination and care management that the plans are doing. We wanted to highlight a few plans, different types of plans, I-SNPs, C-SNPs, and D-SNPs, and sort of have them from different parts of the country in different sizes and different models to let you really hear about what's going on and what's exciting and innovative out there throughout the country. We have 4 really strong panels, so I'm going to just read a quick brief bio on each of them sort of in the order that they're going to come up, and then I'll have each panelist come up and we'll do a presentation, and then we will leave some time for Q&A for the panel as a whole. So first up is Sarah Belfleur, who is from Scan Health Plan, and she's a manager for special needs plans, and she's responsible for developing and implementing the programs, services, and products serving vulnerable populations, and really has been responsible for defining the organization's model of care, developing new chronic special needs plans, and assisting with organizational efforts around serving dual eligibles. And she actively manages the reporting, education, and integration of special needs plans products in the organization with provider partners. Next, we have Beth Ann Martucci from Cigna HealthSpring, and Beth Ann is the Director of Clinical Operations for Cigna HealthSpring Institutional Special Needs Plans. She has 31 years of nursing experience and has been with Cigna HealthSpring for over 10 years. Dr. Martucci is a nurse practitioner specializing in geriatric medicine, and for the past 6 years, she's also worked as a clinical professor at the Johns Hopkins School of Nursing. After that, we have Laura Brannigan, who's Director of Clinical Services and is currently, she started as the Director of Clinical Services in 2005 with GuildNet and is now currently the Senior Vice President of Quality Assurance and Performance Improvement. The last 8 years with GuildNet, she has been devoted to performance improvement and identifying strategies to improve patient outcomes, and oversees the quality program, staff development, and reassessment departments at GuildNet. And then last but not least is Cynthia Williams, is the Director of Accreditation for the Centene Corporation. Ms. Williams' primary role at Centene is to assist the Centene plans and specialty companies in achieving NCQA accreditation. She's a licensed clinical social worker, career started in behavioral health case management. And then after that, we will have Debbie Van Hoven will come up and make some closing remarks after the panel. And again, we will hear from all 4 speakers, and then we'll open it up to the Q&A for the panel as a whole. So let me bring up Sarah Belfleur from SCAN. Thank you.
Okay. Good afternoon, everyone. I'm Sarah Belfleur from Scan Health Plan. I'd like to thank CMS and NCQA for inviting me to speak on behalf of our SNPs today. And if you've also seen the news this morning, I'm thankful that I wasn't on a Southwest flight and ended up in the wrong city and at the wrong conference, so I'm glad to be here. I want to caveat this presentation a little bit by saying that I'm going to talk about better practices. We know that serving SNP members is an evolving process, and as we learned today, the interpretation of the requirements has changed over time as well. So we continue to research and through trial and error refine how we serve and care for this population. So today I'm going to share some of the better things that I think we do. A little bit of background about SCAN is we serve people on Medicare and Medicaid, and we've been doing it for about 35 years. It was started by a few angry, frustrated seniors that were a little disgruntled with the healthcare system. We are one of the original social HMO demonstration projects. Our nonprofit mission is to keep seniors healthy and independent. We're only in California and Arizona, so we have no polar vortex to worry about. We have approximately 160,000 members after this AEP, with about 20% of that being SNP membership. I also like to take every opportunity I can to shamelessly mention that we are 4.5-star plan now. So this is just a representation of all of the SNPs we have. We have a nice smattering of all different kinds of special needs plans. We have an iSNP, which is an institutional equivalent, so all of our iSNP members are in the community and meet nursing facility level of care. We have a C-SNP heart cardiac plan. We have a C-SNP diabetes plan. We also have a C-SNP ESRD plan, which is a partnership with DaVita Dialysis. We also have two types of D-SNPs. So we have a D-SNP FIDA-SNP, where we have a state contract and we provide home and community-based services to those members. And then we also have a D-SNP where those members do not meet nursing facility level of care and or are in counties that do not have a state contract. So what do our special needs plans provide? As Brett mentioned earlier, there's a whole continuum of SNP members, and some of them tend to be on the healthier side. So on one end of the spectrum, we have healthier seniors that just need preventative care and may say, be there when I need you. These are the members that qualify and have a diagnosis that allows them to be in one of our SNPs, but they're still out playing golf occasionally and they really don't need a lot of attention and intervention. So and those types of members seek out our preventative care, our fitness benefits. We provide care navigators for them to help navigate the system a little bit. And then in the middle, we have our chronically ill where they need transportation or we provide low or no cost medications. For example, in our diabetes plan, we have zero copay for insulin in most of our products, or and same thing with doctor visits, zero copays to visit their PCPs or specialists. In this population, we also provide some complex care management and disease management, and their goal and what they're asking of the health plan is to help me stay healthy and navigate the system. On the other end of the spectrum, we have our frail or end-of-life members that need maybe some in-home services to assist with ADLs. We provide this to our FIDA-SNP members. We provide very hands-on care management and expertise for those that are trained in end-of-life. So in order to accommodate our growing SNP population, we have about 30,000 SNP members now. Earlier this year, we did what we called our 130,000 member tune-up. So in the interest of time, I obviously won't go into details about our restructure, but we did three key things that helped us to become more efficient and I hope more effective in serving these members. Briefly, we added staff and programs, and that means that we added a significant number of care navigators. We added a separate care coordination department, and we also added an advanced illness management program this year. We had a really big project called Assess Smarter, Manage Better, which really streamlined our care management assessments. And this was meant to give our care managers and nurses more time to work on interventions and goals with our members rather than over-assessing them to death. And then we reorganized. We moved staff around so we could be more efficient and best utilize staff resources and skill sets. So this, at the very core of our SNPs and model of care, is our care management programs. This is just a visual of our programs and the general distribution of where our members are served. In 2013, we were adjusting this process to triage and stratify members into the most appropriate programs each month. So we do risk stratification or predictive modeling each month to determine which program might best serve our members. So this is just a general overview of our programs. Our advanced illness management or palliative care program serves members with end-of-life care needs. Complex care management serves those that are at high risk. Our disease management programs serve members with CHF or COPD. Our care coordination department assists members with access services or transitions. And for those on the healthier side of the continuum, we do what population health management, which is outreach to these outreach efforts to these members based on data mining and predictive modeling. So some of the better practices I think that we have is in our staffing. We have what we call a PAL unit. It's a personal assistance line, It's a dedicated bilingual customer service for our dual eligibles. They specialize in Medicaid benefits and eligibility, and they do welcome calls to all of our DSNP members. During that welcome call, we mail them a magnet with a copy of their PAL so that they could stick it on their fridge and they know who to call, and it has a picture of their PAL. So it really helps to develop rapport, and they know who to call when they need assistance with their Medicaid benefits. Again, in 2013, we added care navigators, and these folks do educational calls and care coordinations for our staff. They do med adherence calls, and we look at data to see where there's gaps in care. And so they'll call up members and figure out maybe why they didn't refill a prescription or why they hadn't had a particular screening, and really help close the gaps on those. So better practices in our HRAs. We've tried it all. We've done mail, we've done IVR calls, the automated robocalls, we've done regular phone calls, we've done in-person calls. And as you might guess, this population obviously respond a little bit better to calls and in-person assessments. So this year we nixed the mail and IVR. We got rid of them completely. And while this is more resource intensive, we have gone to all phone calls and in-person. In addition, since we have some non-clinical staff that are conducting these HRAs, we've taken the guesswork out of how the member is referred for care management or any other program. So based on how the member responds to the questions, we have automated reports and prompts that go to clinical staff. So the care coordinators can really just focus on doing the assessment and not determine whether or not the needs are being addressed. So we'll send that to a nurse for review. So some of our better practices in care transitions, historically we've employed an only telephonic model, but now we are realizing that we have some opportunity to do some home visits for some of our high utilizers or members hard of hearing in certain geographies. Typically, we used to empower our members to make their own follow-up appointments with the doctor after a hospitalization. Now we're really kind of helping and kind of holding their hand a little bit in some of these instances and doing a conference call with the MD office. Historically, our assessment would just ask a member if they understood their meds and their discharge instructions, but now we're doing more comprehensive probing and medication reconciliation because some of these members would say, yes, I understand, and they may not really understand their discharge instructions. In addition, care transition coaches may have struggled with complex end-of-life issues, so now we have specialized expertise in a specialized department for advanced illness management, and so we do referrals over to that program. Another thing that we've tried out this year is to do a care transitions pilot, and we continue to look for innovative programs to serve our SNP members. In this particular initiative, we look to use technology to serve our SNP members. So we did a 3-month pilot on this video messaging format, and the goal was to improve engagement through personalized interaction and reduce readmissions. So this platform would help us to send video messages for medication and appointments through computers or smartphones, and ultimately, we found that we really had some barriers with technology and patient health status. So we offered the program to about 235 people. Only 36 agreed to participate, and only 12 of those actually viewed the messages. So we may be ahead of ourselves as how receptive some seniors may be with technology, but we continue to try these things out to see if it's an opportunity to engage our members. So with more members enrolling in our chronic SNP plans and SNP members having comorbid conditions in general, we've researched programs to address depression in this population. So as you can see in the little cartoon, are you depressed because you have diabetes, or is diabetes causing your depression? Yes. We know that this is really an issue. So in particular, we're committed to implementing the IMPACT program, which stands for Improving Mood and Promoting Access to Collaborative Treatment. And it's an evidence-based model for reducing depression and improving clinical outcomes. And it uses a trained embedded care manager in the PCP's office. So they collaborate with the psychiatrist. And so we're in the process of identifying our provider partners right now to implement this, particularly in some of our underserved geographies. So this program uses a structured program to assess and monitor depression using the PHQ-9. In absence of a single EMR, we've had to find a solution in the last few years. So the challenge has been sharing information with all of the stakeholders. So one of the things that we've been able to do that I think has been helpful is set up this SFTP site, a secure file transfer protocol, where we can really share this information with our providers. Every month we put a SNP membership report out there so all of our providers know who their SNP members are. Sometimes it's hard for them to distinguish who their MA members are and who their SNP members are. In addition, we put weekly care management trigger reports on this SFTP site as well. So for all the HRAs that we complete, we have an automated process that sends a report to the providers and lets them know if members trigger and the reason why they triggered for potential care management. So we think these members could benefit from early interventions. So they've indicated they have multiple ER visits, they've had multiple falls, or they have severe depression. And this is all self-reported data, and these members are just coming into our health plan. We really think that this is helpful information in collaborating and providing good care. In addition to that, we have an auto extraction of all the health risk assessments and care plans that we complete, and also have that put onto this site as well so that the providers have access and they can take a look at what the member, how they responded to the health risk assessment. So with that being said, I know I went through this really, really fast, but that will give opportunity for lots of questions at the end, I'm sure.
Thanks, Sarah. So now it's Beth Ann Martucci is going to come up and talk to you about her program.
Hello, everyone. It is my pleasure to talk to you today about best practices in care coordination and care transitions. I'm from Cigna HealthSpring, and we have an institutional-based program that serves beneficiaries that reside or are expected to reside in a long-term care setting for 90 days or greater. Our program is a treat-in-place program. We work as close as we can with facilities to treat our members in place whenever medically feasible. Just kind of like a snapshot of our membership. It's largely female, that are mostly cognitively impaired, in fair to poor health due to multiple chronic illnesses, low income and over 81. We have about 1,256 members, and I guess I could move this along so you could follow me. We have 1,256 members in 42 buildings in the Pennsylvania and Maryland markets. We have 24 dedicated nurse practitioners to care for these members. Each one of our members has a nurse practitioner, and that nurse practitioner also serves as their case manager. They've developed a very close relationship with the families, with the facilities, and with the PCPs, the attendings in the facilities. We work very collaboratively with our partners. We also have a dedicated care coordination team of 4 care coordinators. Each one of these care coordinators has a pod of about 10 facilities, 10 to 11 facilities, and they are very member-focused. They work closely with the facilities to arrange appointments, transportation, order DME. They're the nurse practitioner's right hand. For example, our care coordinators, they take the administrative burden off of the nurse practitioner. So if we have somebody in the facility that, say, has pulled out their feeding tube, and to keep them from having to have an ER visit, we have them work with a nurse practitioner and arrange for like a visit to the GI specialist or to one of our living well centers. They'll arrange the transportation, set up the visit. We'll call the physician or the hospitalist that we're going to transfer the member to, give them kind of a little bit of a background about what's going on. Our member has the G-tube replaced and comes back to the facility. We have also one RN case manager. We just brought her on last year. And basically what she does is she works with the quality metrics, our HEDIS and STARS initiatives, but she also is in charge of our care clinics. As part of treating in place, so the care clinics, we have like ophthalmology and podiatry, audiology, and I'm missing one. But what they do is we basically bring the clinic into the facility. And so, say ophthalmology, it's time for our diabetic to get their every 6-month evaluation. We'll bring in the ophthalmologist along with an optician. They go ahead and see the members. We'll bring them into a central meeting place. Sometimes it's into the dining room that's not being used, or sometimes it's the hair salon that's not being used, but a place within the facility. And the ophthalmologist will see them, and if they need to have glasses, then the optician can go ahead and fit them at the same time. The facilities love it because we keep them from having to go out. The patients love it because they don't want to go out in this cold weather, nor do they want to be in that Hoyer lift that puts them on a stretcher. So it's a win-win. I want to talk to you a little bit about our clinical team because it does provide integrated healthcare management. Our nurse practitioners do this comprehensive history and physical 30 days upon receiving the new member, and then annually thereafter. Our history and physical is it's a loaded document. It's much more than just your typical history and physical. It contains the components of a history and physical, of course, but it also does the screenings. We look at fall risks, we look at cognition, we look at functional status and pain, we look at advanced directives. And from that history and physical, we develop a plan of care for a member. That plan of care follows the member through the whole year. It's updated monthly with every comprehensive visit that the nurse practitioner does. That care plan is it's shared with the family, it's shared with the facility, it's shared with the PCP. It's their care plan. So then what we do is we have a risk assessment tool that talks about how we're going to the visit schedule for the member. That risk assessment tool is it's divided into 5 levels. Level 1 is our hot members. Those patients are seen daily until they stabilize. They're in immediate risk or jeopardy for going to the hospital. So we see them and we follow them closely. As they improve, then we'll put them down to a risk level 2. And a risk level 2, you see them every 1 to 3 days. As they're improving, they go on to a level 3. A level 3 is they've had a prior 1 or 2, and they're being seen weekly. You see how we kind of do this? Then the level 4 is they're stable patients, and we see them monthly. That's the comprehensive visit, and that's where we go ahead and update the plan of care. If it remains the same, we just keep it the same. If there's a change in condition, we update it. And then a level 5 is just kind of like a quick or focused visit. If a member goes out to an appointment and say they're a congestive heart failure patient, we've changed some medications, we'll make a note of it, but they're a stable patient and they're seen monthly. Say that we're doing everything we can to prevent somebody from being hospitalized. We've got our care coordination in place. We've got the nurse practitioner seeing the patient pretty frequently on top of the physician. The physician's still in there. The nurse practitioner is just an added resource. So say we're doing everything we can, but the patient has a decline. We have a hospitalist group that we work with, and our hospitalists also have staffing at our Living Well Center. And our Living Well Center is an urgent care center. It's set up to do some telemetry. It's got radiology services and some lab services. So we often use that site to avoid a hospitalization or ER visit if we can. Our EMR also works with the Living Well Centers, which is also in the hospital setting. The docs can go ahead and access our EMR as well, our hospitalists. So we're doing everything we can. We're treating them good. We're treating them in place. We got these resources. But as you know, there are things we can't treat. And so say they have to go to the hospital. Well, then we let our hospitalists know, and usually at this time they're already involved. So they're there and they're waiting for them. They've got the update, they've got our recent notes, they've got the whole patient's file. So it kind of makes it like a seamless transition. The nurse practitioner at that time will fill out a hospitalization log, and this hospitalization log is it's an Excel spreadsheet, and it holds a host of data. Excuse me. It on this hospitalization log lists the member's name, the date they were transferred to the hospital, the time they were transferred, the diagnosis, their advanced directives. I think there's a host of things. And basically what we do is we use that information at the end of each month, we aggregate that, we develop a facility report, and we share that with our partners. So if we have a patient that's a frequent flyer, or we're seeing a diagnosis that's a frequent diagnosis, like a lot of pneumonia admissions, we can talk to the facility, we can do in-servicing, it's areas of opportunity that we've noted, and we're working with our partners to provide best care. I'm sorry, it's dry in here. Woo. So the unplanned, and so this is also, most of the time this is considered an unplanned transition unless it was a scheduled surgery. So we also have another tool, that's our unplanned discharge tool, and this tool is, it's filled out by the senior clinician, which is also a nurse practitioner, and that clinician looks at what was happening before the member had to go into the hospital. So were they skilled? Was there something that happened that could have been, you could have seen, caught a little bit earlier? We bounce all this by our interdisciplinary care team, which consists of our pharmacist and our psychologist, I think, our nurse practitioner or nurses. Did I say pharmacist? They're all on that team. And we look at this and kind of like basically grand rounds. What could we have done differently? Did we miss something? And we also share that with our partners. It's all about prevention. So as we're looking to improve outcomes, I think I mentioned a bunch of this, our ICT. I meet with the nurse practitioners daily at 9 o'clock to look at the facilities, what's going on the ground, what's happening in the facilities. Do we have flu in the building? Do we have a GI outbreak in the building? Do I need to put resources, just rally up the troops and make resources go to a building? Pay a lot of attention to what's in the moment. I have weekly care coordination teams to improve efficiencies. Excuse me. Okay. Ooh, that's much better. Right. So how we monitor our performance. We have a dashboard that has what we do on a daily basis. I guess we have goals, and the measures, the reporting, the goals, it's all on this dashboard. And we present it monthly to our executive team, and we also report it quarterly to our quality team. Let me think. Oh, these are other things we put on our dashboard. Our MP notification prior to unplanned discharges, readmissions to the hospital within 30 days, HEDIS. It's sort of our nurse practitioner scorecard. So I guess what I wanted to say is we have a strong ISNP program. I think if I had to say what gave us our strength is probably our communication and our collaboration, as well as the shared resources that we have with our SNF partners. It's all about the communication, and I would be glad to meet with anybody after or discuss any questions if you have any that you'd like to bounce back off of me. All right, thank you.
Thanks, Beth. And next we will hear from Laura Brannigan from GuildNet.
Hi, I'm Laura Brannigan, and I'm here to talk today about GuildNet, which is a special needs plan, but it's also a fully integrated dual eligible plan. And we're in New York City. We cover 4 of the 5 boroughs of New York, not Staten Island, and we also cover Long Island, which is Nassau and Suffolk County. A little bit about Guild. Our parent organization was established in 1914 with a mission to assist those with vision loss to live independently with dignity. We're a not-for-profit, non-sectarian organization, and we have just recently merged with Lighthouse International to become Lighthouse Guild International, and we're called Jewish Guild Healthcare. These are some of the services that we offer within Jewish Guild Healthcare. We have low vision clinics, medical model adult day healthcare, diagnostic and treatment center, site care training for those with vision impairment, and also with for their caregivers, our own staff, and any of our vendor agencies. We have a school for children with vision impairment, and we also have the GuildNet product line. GuildNet was established in 1997 as a partially capitated Medicaid long-term care program. It was first opened in 2000 in New York, in Manhattan, except for Staten Island. We currently expanded into Nassau and Suffolk counties in 2007. We added GuildNet Gold, which is a Medicare Advantage special needs plan, Medicaid Advantage Plus, a mouthful, in 2008. And we have GuildNet Health Advantage, which we opened in 2012, which is SNP without the long-term care benefit. We expanded into Westchester and Staten Island in 2013. And although to my colleagues, I have a small program, we have 15,000 members in all of our programs altogether, and over 600 of them are in GuildNet Gold. And we have 400 employees in 4 different sites. The demographics of our membership, our average age is 77.8 years of age. 71% of them are female. The ethnic distribution of this program, they're 50% Hispanic, 23% Black, 16% white, and 10% other ethnic distribution, primarily Asian. The primary languages spoken, 43% speak English, 47% speak Spanish, 5% speak Chinese, 1.5% Russian, and 5% a smattering of every language that is found in New York City. And our staff actually mirrors those languages, but we also can facilitate translation in 150 different languages through Language Line. Our goal is to maintain our members in the community. So 99.1% of our members live in the community, and 0.9% reside in skilled nursing facilities. In order to maintain them in the home, we actually provide aid service for them to help with their activities of daily living and independent activities of daily living, which can range anywhere from a few hours a week to 2 12-hour shifts of aid time in the day. We also offer consumer-directed personal assistance service in which the members can actually locate their own non-skilled workers, train them, and supervise them. And this is very helpful in areas that are very difficult to service or for our members that have particular language and cultural needs. So GuildNet's mission is to provide comprehensive care management services to the blind, vision impaired, and multi-disabled individuals. We promote GuildNet members functioning with dignity in their community for as long as possible. We add value to our members in the healthcare system by coordinating the most effective healthcare services for our members while achieving optimal outcomes, promoting health knowledge, wellness, and safety. Vision impairment actually contributes significantly to excess hospital length of stay. It adds approximately 2.4 days to the average length of stay. And these members are more likely to require rehab services when they're discharged. They have more problems after discharge with emotional, physical, and social functioning, and they are often less satisfied with their health care. GuildNet Gold is a fully capitated program. As I mentioned, it's a Medicare Advantage, Special Needs, Medicaid Advantage Plus, fully integrated dual eligible population. And for the past 3 years, even though we're a small enrollment plan, we've participated in the health outcome survey and have received a frailty bonus because of our membership. Our members must also be determined skilled nursing facility eligible by a score of 5 or more on the Universal Assessment Tool. This is a standard health risk assessment tool for this type of program in New York State. It's a comprehensive assessment tool that includes a community assessment, a functional assessment, and a mental health assessment. And this assessment tool is used by our reassessment nurses who complete the UAS in the member's home or place of residence within 30 days of referral. They begin developing the member's plan of care. The areas that we service are, as I mentioned several times, New York City and Long Island, and all healthcare services are covered. The goal of the plan is to improve health outcomes by improving access to and coordination of care. We're a zero-cost share plan. There are no deductibles, no premiums, and no co-pays for prescriptions. We provide integrated Medicare and Medicaid services through a special partnership with Emblem Health, who provides our network of physicians on the Medicare side and do the Medicare administrative function. And then GuildNet provides the Medicaid network and also the administrative functions. There's a primary point of contact for all of our members. Upon enrollment, everyone is assigned either a case manager that is a registered nurse or a social worker, and they also lead the interdisciplinary team. And there are a variety of additional departments that support our care management. We have the quality department. I have to give it a plug. We have also they oversee the model of care, structure and process, CCIP, QIP. We have the staff development department that trains everyone in the model of care, best practices, protocols, etc. And then we have the Medicare Services Department that is very instrumental in making sure that we adhere to all the regulatory by federal and state standards. As I mentioned, we have a network for our Medicare for duly covered services that is provided through Emblem Health. They're credentialed by Emblem Health, but we also offer a point of service option for our members. So anyone that accepts Medicare reimbursement, our members can go to them in or out of network. And for GuildNet, we provide the Medicaid long-term care network, and that's credentialed through us. And we have over 700 different licensed home care agencies that we contract with. We have medical model and social model daycares. We provide transportation, dental services, inpatient, outpatient rehab, anything that Medicaid covers in New York, that's what we cover too. Our providers are encouraged to use evidence-based best practice guidelines that are generally through the national recognized organizations such as the American Heart Association. And our physician, also our medical director, sits on the Emblem committees that help to develop some of the best practices and disseminate them, which are also found on their websites. The care management model that we use is probably familiar to many of you. It's person-centric. The lead of the IDT is our case manager, who also collaborates with the primary care physician, any of the other healthcare professionals, home health aides, and family members, anyone that the member designates to be on this committee in order to develop their plans of care. The care coordination strategy that we use, we're a telephonic case management model. So everyone gets a telephone call a minimum of once a month by one of their case managers. within 30 days of a referral to our agency, a registered nurse goes into the home, completes the universal assessment tool on them, starts to develop the plan of care. Within 2 weeks of enrollment, they have several points of contact with our agency. We have a transition team that ensures that all of the initial services on the plan of care are implemented. The member service representatives then authorize these services, and then the case manager reaches out to them to see if there are any changes in the plan of care that are necessary and to implement any additional services that might be necessary. They also reach out to the physicians to make sure that they're willing to participate in the member's care planning. And then minimally once a month, there's the outreach phone call to the members. In addition, every 6 months, we see our members in their home to do a complete UAS assessment on them, and also whenever there's a significant change in their condition, such as when they're discharged from the hospital or a nursing home, or any major change in their conditions. So the process overflows. We assess the members, we plan them using the IDT, completing a comprehensive initial personalized care plan. We act on evaluating their benefits and community resources, deploy referrals, services, resources, and implement the care plan. We communicate this to the physicians through either the mail or fax. We mail our members their care plan. We follow up monthly and as needed with them to change their goals and identify additional barriers, and we continue to modify their plans of care. Some of our challenges were with transition best practices, so we revised our protocol. We were having some problems obtaining discharge reports from hospitals and notification of transition from our members. So once we changed our protocols, we continue to audit our transitions that are unplanned and readmissions in less than 30 days. We monitor their adherence to our protocol for medication reconciliation post-discharge, and also encourage them to make a PCP visit within 2 weeks of their discharge to hopefully prevent further hospitalizations. And we continually give feedback to the case management team. We use short-term work group formation. Multi-departmental teams are focused on implementing rapid cycle QI projects. We focus on implementing interventions and then disband. For our PCP collaboration, we felt that we weren't really communicating well with our physicians, so we developed a standard fax form that we write fax directly from our electronic medical record to our physicians. We also, in transition of care, identified that the communication to receiving facilities was lacking, so we created an expanded member information sheet in which has demographic information, medications, their diagnosis, and also any of their advanced care planning documents, which we fax over to our receiving facilities. So we try to align our required quality projects, the CCIP, QIPs, and our state initiatives with our model of care goals. We try to select 2 to 3 core ideas to drive all of our improvement, and GuildNet focused on increasing collaboration with the plan and PCP, increasing the number of our wellness visits to the PCP, and streamlining our care management process for transitions of care. Putting it all together, a special needs plan needs to focus on a few core objectives to drive improvement, and barriers may be significant with this dual eligible population. We try to focus our model of care evaluations using a series of core metrics. We focus on our HEDIS improvement and our member satisfaction. GuildNet is hoping to join the alignment and become a fully integrated dual advantage plan in New York State. And we are hoping to continue to focus on our quality initiatives to improve our star ratings and to also get incentive bonuses. And I'd just like to end with a quote from one of our 91-year-old members. She states, "GuildNet adds quality to my life by providing a network of services which saves me a great deal of anxiety and stress." She then states that she hopes to have many more years of living at home with independence and happiness, and she thanks GuildNet for making it happen. Thank you.
Thank you, Laura. And now I'd like to bring up Cynthia Williams for our final presentation.
Hi, I'm Cynthia Williams, and I think I understand how my kids feel now when they complain that they always have to go last because their last name starts with a W. So I think I understand them now. I am from Centene. Centene is a multi-line healthcare organization with health plans in 19 states. In addition to our special needs plans, we have recently entered the exchange or marketplace, the Obamacare. We have a few MMP plans coming live soon. Primarily, though, our business is Medicaid. We have CHIP, ABD, foster care, long-term care, TANF products, pretty much any Medicaid-like product. We have members in those products. Centene also has a lot of specialty companies. So we have a nurse hotline, we have a behavioral health company, disease management, vision, pharmacy benefit manager, specialty pharmacy, and telehealth services. So it brings a big advantage to us because we can partner internally with all those different specialty companies. So today I'm going to give a very brief overview of our Centene SNPs, but I'm going to focus much more narrowly than the other speakers. I'm going to focus primarily on our care transitions oversight and how our oversight has evolved over the last few years. We first submitted to NCQA in 2009 for the structure and process measures. So I'm just kind of go through what we've, again, our evolution of oversight of the transitions. Okay, so all of our SNP plans with Centene are dual eligible. I have the states listed here. We're in 6 states, and I'm not going to read them for you. We only have about 6,500 SNP members, and across Centene we have just over 3 million lives. So obviously our SNP population is a small percentage of our overall population, but of course they keep us very busy. Our contracts arrangements do vary by state. I have them listed here. So 3 of our states, of course, they have Medicare with Centene, and they can have Medicaid with Centene as well, or with another MCO. And then in 3 of our other states, the members must have fee-for-service Medicaid per the state requirement. So that can pose some challenges with coordination between Medicare and Medicaid, and in trying to standardize processes when we have, again, some members have both products with us, and other, there's just various arrangements. So again, I am going to focus specifically on care transitions. Of course, we initially developed a policy and procedure to meet SNP 4 requirements. Our first draft of our policy was very straightforward, kind of just regurgitated what the SNP 4 structure and process measure stated. Then we created an audit tool because we needed a way to monitor our performance and to analyze our performance on how we were doing with the requirements. The audit tool was very basic as well. Basically, it stated the standards, those initial 6 factors, SNP 4, it just stated those, and then we were checking to see if the requirements were met or not met. And our membership grew very slowly. Again, we're only at 6,500 members now, so we literally started 10 members, 20 members. So as we started doing more of the audits, initially we did 100% of audits because we had a very small population. And as we started doing more, we realized that, it became evident pretty quickly that the audit tool needed to be enhanced. So, we knew we were doing it or not doing it, but we didn't know why. We didn't know what got us to that point or what we missed that caused us to miss the requirement. Okay, so here's just a screenshot of our original audit tool. Again, very basic, just listed the, pretty much word for word from the SNP 4 structure and process measure, if it was met or not met, the date it was met, and then we had an NA. And again, we couldn't identify, we had no way of knowing what got us to compliance or what caused us to not be compliant. So in order to identify those activities and tasks that we needed to add to the audit tool,
first we mapped out the process. So we wanted to know each step of the way, what got us there, again, what did not get us there. So eventually, after many, many drafts, and I became a Visio expert, I think, we ended up with 5 workflows. So they're listed here, plan transition from the hospital to inpatient, inpatient to next setting of care. So we did 2 for planned, 2 for unplanned, and then we kind of did all other transitions. So now we're using those workflows as, they're an attachment to our care transitions policy, and then we also have them as job aids for our staff. We want staff to be able to visualize, because there's a lot of information in the policy. As everyone knows, there's a lot in SNP 4, and so we wanted to try to simplify it, break it down a little bit. So here's just an example of one of our process flows. We didn't want it to we took a lot out. We didn't want it to be too cumbersome, but we wanted to look at each piece, and again, first determine if we needed it on our audit tool, and then how can we capture it on our audit tool. So here's an example of our process map for plan transitions from member's usual setting of care to inpatient facility. Okay, so our improved audit tool really captures each piece of each of those processes. For example, we're now capturing whether it was met or not met for if the CM requests the sending setting to share the care plan with the receiving setting, and then if the CM follows up to confirm that the care plan was actually received by the receiving setting, and then if needed, a second attempt for the care plan to be sent. So that's just an example, but we're getting every step along the way. So then we can go back and look, okay, where did the process break? And of course, we obviously also ultimately capture whether the requirement was met or not met, but we know each step of the way. So here's a screenshot of this is just part of our audit tool. This is actually the instruction guide. The tool itself is in Excel. It just has the questions that you see all the way to the left, where Q1, 2, and 3, question 1, 2, and 3. I think we have a total of about 17 to 20 questions. So, when we're actually doing the audits of cases, we just have it in Excel for easy scoring. But this is actually the instruction guide that goes along with the tool. And you can see at the top, we have to the hospital. So the way we formatted it, so it follows the case progression. So we have a to the hospital section, we have another additional care setting, if there is an additional care setting, and then we have a from the hospital section. And you can see we have clear definitions of what is a yes or met and a no or not met. And then all the way to the right, we have additional information. So we got very specific. The instruction guide kind of sums up most of what is in SNP elements A and B. So it kind of really dives into a lot of what's in the explanation in the SNP 4, the structure and process measure. And another thing I want to point out is I didn't foresee this, but the definition of not applicable became very important. Because when we were doing these, in the beginning, we were getting a lot of NAs, and of course they skewed our results, and we're like, okay, and I would look at her, somebody else, and they said, well, I wouldn't think that was NA. So we're like, okay, we need to define for every question when you can choose NA and when you can't. So you can see I have grayed out, NA does not apply for this element, so it's not even an option. And then for each, again, we did this for each question where, and as we looked at more and more cases, as our membership grew, we realized, there's, real life gets in the way, of course. So there's all these scenarios where you realize, okay, question 3 is NA because we're not going to request that they send the care plan if we're not even notified of the admission until after they've already been discharged. So I feel like every time I look at this instruction guide, I could change something. And then now we have, the audit guide, or the instruction guide and the audit tool was really meant for not just for the staff who's auditing cases, but for the frontline staff who is actually managing the transitions. This is not something we hide, and it's not they're given a test. We want them to read this. That additional information has some some details about different scenarios so the questions make sense to them. So we share this with everyone. It's an extension of our policy. It's a job aid. We want everyone who's involved with transitions to know exactly what we're looking for and why, what's behind it. Okay. So our enhanced audit tool allows us to perform more detailed analysis. We can identify specific barriers and opportunities such as staff or provider training. And then it's also allowed us to promote consistent standardized documentation. For example, one thing, once we put all those additional questions in our audit tool, and we knew, we could then determine, is this an issue? We didn't meet the requirement because the staff didn't do their part, they didn't request that the care plan, or they didn't verify that the care plan was shared, or is it because the hospital or whatever setting of care didn't share the care plan? So once we were able to determine kind of who didn't do their part, we were able to, get down to more detail on, okay, we have a staff training issue. And then, for example, so we looked into staff training and we talked to staff, we kind of did an assessment of the staff knowledge. And then what we determined is most of our staff knew the requirements, they knew what they were supposed to do, but the documentation was not very consistent. They may have met the requirement or partially met the requirement, but it was buried deep in a long free text note, and there's a lot going on with this member, so you'd really have to tease through it and, oh, there it is, So we realized a lot of it was not necessarily the lack of staff knowledge, it was they really didn't have the job aids or the tools to be able to document consistency and clearly. So what we did, one of the things we did is we developed some standardized tools. So we have a fax template for notification of the transition that's sent to the member's usual practitioner. It's one form, it's in our clinical documentation system, so all staff have access to it. It's just notification, your patient so-and-so has, experienced a transition to the hospital, from the hospital. It's got each setting of care to and from. It's got a little more information about requesting the care plan if that's applicable for the situation. Again, they can just use one form. That can be the notification. Another thing we did is we implemented a structured note. Our clinical documentation system allows us to create fairly quickly what's called structured notes, and they're kind of mini assessments where you can put specific questions in reportable fields. So we can put, date care plan was requested to be sent to the receiving setting. And they can enter a date, can be a date field, enter a date. And then, next question, was the care plan received by the receiving setting? And they put yes or no. So we can then report off that. And so it always, aside from capturing the information, it's triggers for staff to remember what questions to ask each time and what they need to focus on. We also, we always have free text fields too. I always tell when I'm doing audits and I'm talking to staff, I always say, I don't want just the box checked, of course. You want to know the story. So we encourage, free text. We want to know what's happening with a member. We don't want just boxes checked. But that kind of structured note does allow us, again, to have reportable fields and to be able to clearly identify the information we're looking for when we're doing audits. Okay. So then for our next steps for care transitions, I feel like this is going to be a work in progress forever, and hopefully NCQA won't change the requirements anytime soon, because I feel like we're still working towards it constantly. So one thing we do want to do is simplify the audit tool to streamline audits. Even with the documentation tools we've created, these audits are very time consuming. They can take 30, 45 minutes sometimes if there's a lot going on with a member, if there's maybe a couple hospitalizations back to back or multiple levels of care. So we do recognize a need to kind of streamline it. We also continue to look at our templates and revise them. We want to make them, more user-friendly and more intuitive for staff that may not have the level of knowledge that some other staff have, so we're looking at that. We also want to enhance our staff training to include practice scenarios. We'd like to use actual cases, from within Centene. I know pulling examples for the SNP4 structure and process measure submission, I'd like to use some of those and say, look, this is what we're actually seeing and this is what we're trying to find. And I think that will help staff versus just, again, reiterating what the standards are. We want to develop additional provider educational materials. And then we've done some general education with providers, but we want to look at when we identify that it's not a staff issue, it's a provider issue, we want to be able to target those individual providers who maybe don't understand the requirements or really need some additional education versus just kind of a general education to all our provider network. Some of the other things I didn't put on the slide here is we also want to look at building more reports to kind of measure some of our how well we're doing on the care transition activities. Again, like I said, doing the audits is very time consuming, so we think we can probably do a lot more with reporting than just pulling up every case and reading through all the notes and looking at the entire case. We also want to look at opportunities for provider notification through our web. We're doing a lot more through our web portal for authorization requests and notifications. So I think we have a lot of opportunities there to do more through the web versus just faxing or phone calls. Okay, and that's all I have. So, thank you.
So thanks everyone for that. I think that was really informative, and we appreciate all of the hard work that all of these plans are doing to help members in the SNP program. So I'd like to open it up now for questions both on the phone, if there are questions on the line there, as well as any in the audience. And while we wait for questions, I'm going to take the sort of moderator's prerogative and ask the first question, which is really to ask the panel, what do you see as sort of some of the biggest challenges in coordinating care, especially for the more vulnerable populations that you manage within your SNP programs? We can kind of sort of go down the line, I guess, or if people want to jump in, that's fine too. If anyone has a burning answer.
I think one of the challenges that we've had was mentioned in Cindy's presentation too, is tracking that care plan from one setting to another. We continue to try and make improvements on that process. I think in general, though, initially when we had started some of these SNPs was really getting the providers on board, and so they saw SNPs as really just more administrative burden and us asking them to do additional things. But the more that we've trained them and talked to them about how great our models of care are, we've really started to get them to come on board and really provide really good care for these members. And what we've also done is really select a narrowed network for some of our C-SNPs as well that really provide good quality care. And we feel that that's probably helping us to engage those providers and provide better care for them.
Beth?
I would say probably our greatest challenge is escorts with our patients. We will provide the transportation and we'll schedule the appointment, but they need an escort to go with them to the appointment. And often the staffing in the facility isn't conducive to having somebody pulled out of the staff to go with them. And so we rely a lot on volunteers from the community in the facilities. And I'd say that's probably our biggest challenge.
Sure. Others?
I think some of our biggest challenges, our membership doesn't always have a standard primary care physician. A lot of our membership go to clinics, and we know that the doctors in the clinics are constantly changing, so keeping that communication is a little bit of a challenge for us.
I think, and this is probably for Medicaid especially, but finding the members. We have a lot of, I think somebody mentioned,
getting them on the phone. Mail doesn't really work, getting them on the phone. So finding our members and building a relationship with them is often difficult. And we do have a group, they're called Member Connections, and they will visit the homes, and they'll go, try to track down the members wherever we can, and that has been very helpful. But it's a challenge sometimes just finding the members.
Great, thank you. I want to see if there were, I thought I saw someone coming up from the audience if there was a question. Nope, I guess he sat down. I just want to quick, Danielle, are there questions if you can open the phone lines or if there's anything over the chat?
Question on the phone line. Please hit #5 to unmute your lines. This will allow you to get in line and ask the question. Again, that's #5 to ask the question on the phone line.
Okay. While we wait for some questions to come up that way, I had one more, I have a couple more, but I think one more I wanted to ask about. How do you manage your, the care teams and really sort of, how do they interact with each other and with the members? Maybe talk a little bit about how those that kind of coordination works with the different care teams.
I think it's a combination of attempts. I think with 30,000 SNP members, it's difficult to get everybody all in the room at the same time. So we have really relied on stratifying our members for the very complex and getting those teams together and presenting at IDT on a weekly basis. But for those that aren't reaching those higher tiers, we're really doing that more virtually and having our nurses reach out to the PCPs and specialists and documenting that, sending out information, and again using our secure site to share information. And we do get I get calls in particular about what's on there and what to do about it and those types of things. So it's depending on the member and the SNP type and their level of need. It's a variety of in-person and telephone and just virtual communications.
Well, this is probably our area of strength. Since we have a captive audience, they're not going anywhere. They love their nurse practitioner. It becomes part of their family. And the families or the power attorneys love the nurse practitioners too. It's just an embedded resource. And they also get to know our care coordination team because of it's just a small group of folks. Each nurse practitioner only has about 50 patients. So you get to know those families very, very well. And so I think we're in a different kind of than the rest of you.
I think our interdisciplinary team has an advantage in the fact that the care manager has to contact our members on a monthly basis, and so they reach out. The members are looking forward to those calls because they are socially isolated very often. We also utilize our vendor agencies to help locate our members, and we share a lot of the information via our electronic medical record. So everyone that is on the care planning team has an opportunity to see the ongoing care planning process.
I'm probably not the best person to answer that because I'm at the corporate office. I'm not at the plan. I'm in my corporate ivory tower. But I think what I mentioned before about having connections reps that go out into the community to try to, they work with providers too, but they're often non-clinical people from the community, and so they reach out to and will find the members anywhere in the community. And then, as I mentioned before, having the specialty companies, so if there's behavioral health involvement, disease management, nurse hotline, we all share a common system so everyone can see each other's notes, everyone knows what's going on. So maybe there's a behavioral health case manager that's more involved, and the medical case manager can collaborate with them to, maybe the medical case manager can't find the member, but the behavioral health case manager can, and they can share. So I think that's a big area of strength for us.
Great, thank you. I just want to, we're running up on the time here, so I just wanted to see if there were, Danielle, were there any questions in the chat or from the phone line at this time, do you know?
Yes, there is a couple of questions in the chat.
Okay, can you read those now, please?
Sure, I'll start with the most recent from Jeff. His question was, we submitted an MMP application in model of care in 2013 for CY 2014. We received a one-year approval on the MOC, and the plan is scheduled to go live in June of 2014. Do we need to submit a new MOC in 2014 for a plan that hasn't started?
That's a question that's sort of a bit off the target of this panel. I would say that they should submit that to the SNP mailbox at snip_mail@cms.hhs.gov to get a definitive answer. Are there any, do you see any questions, Danielle, that are related to this panel? And while you're looking, I'm going to turn to Rich here in the audience who has a question.
Yeah, I had a question relating to continuity of care in care transitions, particularly as it relates to the content of a care plan. In terms of a caregiver role experience, one of the things that I experienced was a lot of inconsistency in terms of how medications were reported and the kind of management of medications that was used as a person moved, my father, moving from one setting to another where there was always a change, and there was, there was good communication, but the problem related to the content of the communication and the continuity of care embedded within that. And I was wondering whether somebody could speak to that, as part of a monitoring process as it relates to care transitions.
I think I can try to address that. Medication reconciliation is really one of the pillars of Eric Coleman's care transition model. So it seems that perhaps that wasn't occurring with yours, but I think for most of the SNP plans, that's really one of the foundation pieces and things that we do when we work with our members is to make sure that their medications prior to hospitalization or post-discharge kind of either match up, or if there are discrepancies, this is where we get them into their doctor's appointments within a couple of days to make sure that we can make sure that those are reconciled appropriately. I don't know if I answered your question though.
So in the long-term care setting, when a member goes to the hospital, their medication record follows them to the hospital, and so they're aware of what medications they're on. So, they always change once they're in the hospital, but when they come back from the hospital back to the nursing home, the nurse practitioner sees them within one business day, and that medication list that they received from the hospital is also reviewed and bumped up against what they had before they went in, and is reconciled at that time. Plus, we have an on-site pharmacist in every one of our facilities that also reviews that medication at least monthly.
And in our setting, it's very similar to all these other medication reconciliation types, but when they're discharged from the hospital, very often we authorize to have a certified home health agency go out. So they're visited within 24 hours of discharge, and then the nurse that's out in the home actually will do the medication reconciliation and contact the primary care physician to ensure that the medications are what was ordered and what needs to be taken. They get rid of the old things and throw them down the toilet, but things like that.
The only other thing I could add is our clinical documentation system has a separate medication module where all the medications are listed with the exact dosages, and our case managers just review that with members or caregivers at every contact, at least to verify whether something has changed. And then our system does track. It has, the original medications when we first assessed, and then it has dates for when we reassessed.
Okay, great. Well, thank you. I'd like to thank our panel once again for a wonderful presentation, and we're almost through with the day. Thank you. I'm going to turn it back over to Susan Radke, but before I do, I want to make one more announcement. First of all, which is thank you all for this. We will be sending out evaluations probably in the next week or so while it's still fresh in your mind via email. So we certainly would hope that you will respond and provide feedback to this. We do take that seriously, and we do want to improve and do these better and provide the information that you need and that is pertinent to help you. So please, when you see that feedback survey, please respond. And then the last thing is when you head out, before you leave, if you could drop your badges off at the door. We do try to recycle those and use them for all of our conferences. So thank you, and here's Susan.
Well, thanks for hanging in there with us. I am very happy and pleased to introduce to you Ms. Debbie Van Hoven, who is the Director of the what are we? Division of Analysis and Planning. I'm getting all my divisions mixed up. So with no further ado, here you go, Debbie.
Thanks, Susan. Well, it's that last few minutes of the day when everyone has been sitting here all day and thinking, oh, no, I can't possibly hear anything else. So I will make it brief. But I just wanted to indicate, first of all, I hope that this session today was of value to you. We appreciate all the time that you've taken spending an entire day with us. So hopefully it was worth your efforts here. I do want to, as evidenced by some of the presentations earlier today, we feel we've made great strides over the past year to refine our requirements for the SNP program in conjunction and in large part through input and feedback from you, so we appreciate that. And we really do look forward to continuing this dialogue and our collaborative efforts as we seek to improve the future of the program and, most importantly, best serve the needs of the beneficiaries enrolled or eligible to enroll in these programs. So on behalf of CMS and our co-sponsors NCQA, I do want to personally thank all of our presenters today, particularly those who have traveled great distances to be here, specifically Ann McMillan from our Chicago regional office, and certainly the plan representatives that who you just heard from. So we do appreciate all of you for the time that you took and the information that you imparted here today. Brett took care of a couple of my housekeeping items, but I will reinforce we do want to get your feedback in terms of this session. It's very important that we have your input because it will help us inform the structure of our future such sessions. So with that, thank you all for being here. I know many in the audience had to travel for this today. We appreciate all those who attended via the online webinar, though I apologize. I realize that there had been some technical difficulties with that today, but we will have the slides and I believe the audio recording of this session available on the NCQA website. The other thing I will remind folks about is, in case you weren't following, on Friday we did release a memo regarding upcoming training sessions for the 2015 contract year application process, which includes the submission requirements and the details regarding that application. So if you missed that, please look for that HPMS memo. There is a training this Wednesday the 15th along with next Wednesday the 22nd. So that's in addition to the MOC-specific training requirements that we talked about earlier today. And with that, just a reminder, as always, there's always the SNP mailbox. If you have specific inquiries, we'll be manning that, particularly in the coming weeks, and we'll be sure to respond to your questions very quickly. So with that, we'll adjourn for today, and I wish you safe travels. Thank you.